All right, so I'm going to introduce our sponsor, Elise. She's from Curamedics. She is very good friends with our physicians tonight. She's going to give us a sentence or two about them, then I'm going to take the reins back and introduce and embarrass all of our panelists effectively. So, Elise.
Excellent. Thanks, Anne. Welcome, everybody. I'm very happy to be here and teaming up with Podiatry Meetings. You have two great presenters in the field of podiatry with us tonight, Dr. Michael Chin and Dr. Rob Conanello. I have known them both for many years now. They are a dynamic duo and work incredibly well together. They are two of Curamedic's top key opinion leaders, people we look to and rely on for really how they have grown in understanding Shockwave and now EMTT and how they've integrated the technologies. So you're in for a treat tonight.
Awesome. All right, so I'll introduce our speakers. We have Dr. Michael Chin. He is owner of the Running Institute, which is a sports-minded medical practice in Chicago with the goal to return an athlete to their specific sport. He is a foot and ankle physician and surgeon with a passion for treating the motivated and health-conscious patient. His knowledge in lower extremity biomechanics allows him to treat those ailments at the source. The Running Institute was created from his vision to provide a comprehensive team approach to treating the active Chicago community. Dr. Chin received his Doctor of Podiatric Medicine from the William M. Scholl College of Podiatric Medicine. He completed his residencies at the VA and Stanford University Medical Center in Palo Alto, California, and the Advocate Illinois Masonic Medical Center in Chicago. He is affiliated with the ACFAS, the American College of Sports Medicine, and the APMA. He's the co-director of the Chicago Marathon Podiatry Medical Tent, as well as the team podiatrist for CARA. And before I go further, what is CARA? Because I Googled it and lots of things came up.
Chicago Area Runners Association. It's the biggest running group in Chicago.
Thank you. That was not one of the ones that I saw. I saw all kinds of things. All right, and moving on, Dr. Rob Conanello. He's the founder and sole proprietor of Orangetown Podiatry in New York, a metropolitan-based practice whose emphasis is on prevention and rehab of lower extremity pathologies. His mission is to empower the athlete within by treating all individuals as athletes with goals. He's the clinical director of the Special Olympics New Jersey Healthy Athletes Division. He's past global clinical advisor for Special Olympics International. He is past president of the American Academy of Podiatric Sports Medicine, and he's an honorary surgeon for the New York Police Department. He has lectured at and served on the medical staff of many international athletic events, including New York and Boston marathons, as well as the Racing the Planet Sahara race. He serves as faculty for Dominican College and St. Thomas Aquinas College. He's authored several sports medicine chapters and contributes to multiple sports-related texts and periodicals. His 30 years of clinical experience have made him well-rounded in all aspects in the world of biomechanics and sports medicine. So I'm going to turn it over to our speakers. I'm going to turn off my camera and mute myself so that I am not a distraction with all of my glory. And but I'm sitting here listening, and we'll chime back in when the presentation wraps up. Doctors, you want to take it away?
Absolutely. So Rob and I are going to kind of tag team these the slide decks and just kind of go through our experience with Shockwave. It's been pretty extensive. Actually, I met Rob at the New York meeting, and he actually was presenting and was actually really kind of in deep with Shockwave. And it piqued my interest, being that he was in sports medicine, also me being in sports medicine or wanting to get into it. It really kind of took me by surprise at how well the technology worked for things like plantar fasciitis and Achilles tendonitis. So my foray into Shockwave is actually on the heels of Rob. So the first slide is, how do we knock it out of the park with evidence-based Shockwave? I mean, I think that's the part, both Rob and I can say is that it is evidence-based. There's so much research about Shockwave, both with radial pulse wave with focused shockwave, and we can get into the science and the technology behind that. But with both of those technologies, it's like you have two parts in your hands that really can kind of take and move, a case of really difficult plantar fasciitis or Achilles tendonitis or a non-union of a fracture and take it from a non-healed state to a healed state to then getting that person back into sport or whatever their activity may be. So I'm going to hit the next slide here. So you already met us. You found out about our deepest, darkest secrets. I knew that Rob's favorite band was the Kinks, so I did know that. But as far as kind of getting into the meat and potatoes of this, Rob and I are friends, and we talk pretty much every day. Is that true?
Unfortunately, yes. Yeah.
Yeah. I probably call him more than he calls me, so I feel a little
No, absolutely.
secure.
Love talking to Michael. Michael gives me lots of information and makes me a better doctor.
Well, I would say the same. So that's why we're on this call together. So let's pop to the next one. So I'm going to read through these bullet points, and then Rob, if you want to take the next slide. There are so many, like I said, applications. The non-surgical regenerative tool for podiatry. This is it. I mean, honestly, there's nothing in my armamentarium that works harder to treat the things that I see the most, and that's going down the line, like I said, the soft tissue entities, but now it's even tracking into bone non-unions. Like the last time I've had to order a bone stem, or the last time I've had to actually go in and surgically repair a non-union, it's been forever. That's well before COVID. So enhancing patient outcomes, I think that's what we're all trying to do, is that at the end of the day, our goal is to shorten the window of time for patients to heal, to get them back to the sport, and especially for my patients, especially Chicago Marathon's coming up on Sunday, that I want to get them to a point where they're not just band-aided, but I want to get them to the point where they're actually physically healed. And that does differentiate our practice. I mean, it's certainly got a cost to it. There are cost of purchasing equipment, but that pays dividends when you actually get into a place where that machine continues to do what it's doing and to do it that well. So, and then we're improving our income stream. I mean, that at the end of the day, we have to make a living. And I don't think that that's something we should be shy about. If you go to one of the tissue regenerative meetings, or if you go to the ASMST meetings, we talk about that. This is not something that's just free, but it also is something where you have to be comfortable in talking about the cost perspectives and how much is it worth to a patient at the end of the day. Do they want to spend thousands and thousands of dollars on insurance money and maybe get better? Or do you want to get to a point where you're actually taking that money and applying it to something that is actually physically going to work? So that's my take on this slide deck.
Yeah, I mean, if I could just add to that, I think for me, like why Shockwave matters is it's always about helping athletes return faster, right? Without surgery, and give them that option. And Shockwave kind of gave me that bridge between the conservative and the surgical care. And what's unique about it to me is that it stimulates healing. That kind of stalled and just wasn't working. And it's not masking pain, which I think a lot of the stuff that we grew up learning with injections and whatnot like that it was always about well, just make the pain go away with medication or something. But this actually is activating your biology. It's making things work. And I think that's really unique and fun. And I think for us, especially being early adopters, it kind of made us innovators, and I want to be an innovator. I don't want to be just the same as the other guy down the street. I want to be doing something that's unique and different and really, really is helpful and has a lot of good science behind it.
Yeah. I think you brought up a good point. It's like the bridge between non-surgical and surgical. And I kind of coined the phrase of it's like doing surgery without doing surgery.
Mm-hmm.
And at the end of the day, we are taking that tissue through kind of a story of going from point A to point B and getting to that point of return. To, in this case, we talk about sport all the time, but you can have an 80-year-old patient who literally is, let's say, a pretty decent health and just wants to be able to walk or go see their grandkids and not be in pain. So, it applies, as Rob was saying, and kind of in his bullet points before, is like we treat all our patients like athletes. And they may come in, they're like, oh, we don't really belong here. We're not really an athlete. But if you're ambulatory, you're wanting to, achieve goals, you're just as much of an athlete as that person who's striving to get a PR at their, Chicago Marathon. So we got technology overview. This is the fun part, which, to be honest with you, we've seen so many slide decks on technology. I know that some people are maybe not as well versed of what, Shockwave is and how the technology actually, achieves what it does. But most of the people start, and I know that I started with, and Rob can chime in, but I started radial pulse wave or radial pressure wave system, which is EPAT. That's more the kind of technology that started the whole process, using basically a ballistic to create a sound wave through the or a mechanical wave through the tip that literally creates a percussion against tissue. And then Rob, if you want to talk a little bit about focus shockwave.
Yeah, I mean, just to add on to, radial pressure wave, we kind of like use that. And I don't like to call that shock wave, even though a lot of us do. There's definitely a differentiation between it. At radial pressure wave allows you, work on broader tissue, where focus is more pinpoint and deep. And in our case, with the Curemetics, we use electromagnetic wave to get into that area. And EMTT complements it by driving this magnetic energy deep into the bone and a tendon or whatever tissue that we're working with. So what we're doing is we're actually giving like layers of regenerative energy. When you have all three, you can use all three. It's definitely a synergy that it really accelerates your recovery.
Yeah. And I know the technologies, each of them work in, specifics, but increasing blood flow, I think, is, getting neovascularization to the tissue, getting that scar tissue element, especially the chronic stuff, to really break that down. And then kind of getting the cells to communicate. There's so many things we talk about now with growth factors, and whether it's injectable growth factors like PRP, or using biologics in the form of like placental umbilical cord type products. You can enhance that with the use of these products, and it's incredible how synergistic they do work. They don't compete. They really do work with each other. And as far as being able to kind of take that and exponentially, again, get those results, speeding processes up by 30 to 40, even more than that percent in different tissues is pretty impressive.
Yeah, and that ESWT that we talk about, that focus shockwave, it also differentiates and recruits stem cells. That's a big piece, to try to help things along the way. And unfortunately, only the focus shockwave can do that. So that's why I think it's such an important piece to have in your shockwave armamentarium.
That's perfect. So common pathologies that we treat successfully, it's kind of changed, I think, since I started, really, with each of the boxes, so to speak, that we checked off. Radial pulse wave, definitely was plantar fasciopathies, Achilles tendinopathies. Really wasn't being used for nerve entrapments. I do use it for ganglion cysts, and I do aspirate, and then I use the focus or the radial shockwave for kind of working through that tissue to kind of heal that, for example, the rent in the tissue closed. But now it's actually getting into bone non-union fractures, and then even wound care. We do have some case studies that kind of show this. Rob, if you want to take a crack at the contraindications.
Yeah, I mean, I think that's evolved over the years since I've been doing it too. We used to say we couldn't use it over open growth plates. We since have learned we can. Really the biggest areas that we don't want to treat it as over malignancies. Even anticoagulant therapy is kind of taking a back seat. As long as you're careful and you're monitoring your patients, it's okay. I mean, I've done it on people with von Willebrand's disease, and we've actually seen mild, if any, bruising at all. Obviously, you wouldn't want to use your focus shockwave over your lungs. But even then, I mean, I personally had a triple bypass in November, and I used my focus shockwave on my sternum and over my heart, over through the introduction to that through some of our colleagues over in Europe. And I did it post-operatively, and it really, my cardiologist was like, wow, that was really impressive that you healed a lot quicker. So, I mean, to me, it's really, if you don't have a tumor and if you're not pregnant, you can do it on anybody, so there is like limited contraindications nowadays.
Yeah, and kind of bring up the point of growth plates. I've treated my son who had patellofemoral syndrome, and he still had an open growth plate at the tibia, and he does not have a leg length discrepancy. He's standing tall at 6 feet. But with that, it does open up a total box of treatments for those who are adolescent sports oriented. You have so much more in terms of youth sports, travel sports, high school sports. It really does open up the box a bit for being able to treat comfortably. So
if I could just add some of the other common things that I utilize it for that are not on this list. I mean, it's great for runners, right? Runners, what do runners get a lot? Shin splints.
shin splints, yeah.
I use it for shin splints a lot. I've had 2 today with stress reactions. We use it for that kind of scenario. I use it even for turf toe and bunions. It works really, really well for those things. And you can even use it preemptively, if you think a patient has a biomechanical issue that might lead them to have turf toe, you can use it before they have a problem as well.
Yeah. And for bursitis, I use the EMTT for bursitis. I kind of quickly put that list together, but safely, instead of doing a cortisone injection on patients for retrocalcaneal bursitis, I've actually implemented this, and it's worked perfectly. And stress reactions to the calcaneus, same thing. So there's other indications that we can touch on. Certainly, if people have other questions on that, but it does open up a breadth of treatment options for pathologists to see.
Michael does say we do talk to each other quite a bit, and we always talk about the intriguing cases, and sometimes the ones that make you go, huh, I didn't think it would work for that. And one of those is ganglion cysts.
Yeah.
I've had people who've had like massive ganglion cysts that everyone knows how we go about treating those usually. And I said, let me try to implement Shockwave with that. And I had a gentleman who was a big football player, and he had a massive one. And he had gone through, for me, multiple drainage of that, and it never got better. I did the Shockwave with it, focal Shockwave, and he has never gotten it back since then. And trust me, whenever he sees me at a local restaurant, drinks are on him. So that's kind of nice.
That's a plus for sure. Yeah, and just think, I mean, half those cases go on to a surgical case. 40%, 50% recurrence rates. People are typically then, signing up for surgery because it's come back. But it's reduced the number of cases I've taken for ganglion cyst excisions tremendously. So, sorry, I did not add the, this is my bad. I missed this slide. But Shockwave is an adjunct for surgical procedures. I mean, it's pretty rare that I have to take cases for, Achilles tendinopathy. The cases where I find I'm using it as adjunct on top is actually for bone healing. If I do an osteotomy, I'm using EMTT, I'm using Shockwave, or if I have a patient who has, for example, sometimes, scar tissue elements, tarsal tunnel. I've done a couple of tarsal tunnel cases, and they just had a matted down incision along the medial aspect of the ankle. Radial pulse wave actually works great for that. I think it's by far one of the heavy lifters for scar tissue. And that's not just tendinopathy based. That's looking at post-surgical, based items. For bunions, I use EMTT for post-operative bone healing management. And it's crazy how much faster things get, to repair. You're probably shaving off maybe 3 weeks of bone healing. And then on top of that, you're getting reduced, swelling. Post-op pain management is much improved. Patients aren't dosed up on narcotics. And I mean, thankfully, most of the, cases we do, they're not requiring OxyContin and things like that. But if they can reduce their pain loads and they're reducing, narcotics just in general, maybe if it's that first, second dose, they can go back to work. They can do most things without having that post-op pain and swelling. So,
yeah, I mean, pre-surgically, like I just talked about my own scenario, we use the shockwave to get the tissue as healthy as possible, before we make that first incision, right? And just decreases inflammation ahead of time and scar formation ahead of time. And post-surgery, it's good for those stubborn cases. I like what Michael said, for stubborn healing. It's particularly like those fusions and tendon transfers that, as you know, are going to take a long time to heal as it is, and fractures as well. I'm really kind of like almost scratch my head still that it hasn't caught on more here in the surgical world, especially since young doctors nowadays, they're taught to be very, very good surgeons, and much better than back in my day. So their training is tremendous. But wouldn't it be nice to have something that can help you get there even quicker? So I think that's the next barrier that we're gonna have to try to get over, is to get more doctors and surgeons understanding the concepts behind this.
Yeah, and I think one of the barriers that people have, and especially with a multi-specialty group, or you're talking about a surgically focused group, like an orthopedic group, is that they have a really hard time talking about cash. And really,
Mm.
at the end of the day, money, especially like I have friends of mine who practice at the university level, it's really hard for them to conceptualize a cash pay situation. Rob and I both have private practices. We're, single practitioners. We have the ability to kind of, generate that conversation, partly because we feel comfortable in doing so. But we know that at the end of the day, like as a cash pay option, what are your other options? Especially if you want to look at that, expedited healing, property. So, that can shave, especially for somebody who's maybe a labor worker, if they can get back to work that much sooner, they're putting food on the table, they're putting that paycheck to work. So they're not laid up for as long as that 3-4 weeks additional that we're capturing with the use of EMTT or Shockwave.
And we've been fortunate enough to talk at a lot of these symposiums around the world, and we get it from everybody. They're like, I don't really want to be selling, to my patients. I'm like, well, you sell every day. You're selling what you believe in every day. I don't care if it's a treatment plan for an orthotic or surgery, whatever. You're selling that concept. We're not selling anything that we wouldn't do to our own family, our own kids. So I think that's really important. And I think we'll talk more about how you set those expectations for those patients.
Yeah. So we have two case examples that we put up. We do have an additional one. I just didn't have a slide set in this particular area for it, and it's one of Rob's cases. But we'll start with case one, and this is one of his really interesting cases. And for people who do wound care, or if they're doing fracture management, this is by far one of the coolest cases I've seen.
Yeah, this was an 18-year-old high school football player, was going on to he was recruited to play in college at a Division I college, university, and he was a quarterback. And unfortunately, he dropped a 250-pound weight on his toe. Me and Dr. Chin were actually enjoying ourselves in Louisville, Kentucky at the time. I'll say no more. But I got a phone call. I wasn't available to help the patient. And it wasn't one of my patients. It was just someone that wanted to give me a call and knew about me, and he were in the hospital. And from what I heard from the other doctors on the other line, they said, hey, this gentleman has a crush injury. Foot looks really pretty bad, and we're recommending a distal cymes amputation. And as much as I didn't want to hear that for this kid who had so much potential at 18 years old, I said, listen, I'm not there. I trust whatever you say, and smart surgeon, so go and do what you got to do. And I explained it to the mother, and she was quite upset, but accepted it too. Lo and behold, me and Dr. Chin came back from our adventures, and I was in the office, and in on crutches walks this young guy with his mom. And he said, before we had surgery, we just wanted you to look at it. And this is the first picture that you see on the left-hand side there. And I said, well, I do think, maybe this is gangrenous, and it's a comminuted, really bad fracture, crush. You should maybe consider getting that amputation. And I said, is there anything else? And I was lucky enough to hear one of my colleagues from Switzerland give a very similar case. And I said, the only thing I know is to do a combination of EMTT and Shockwave. But I'll be honest with you, I never did it before. And they said, let's do it. I'm like, oh boy. So here we go. So we went and we did it. And we were aggressive with it. And not only did the kid heal up perfectly, and I need eventually to put like even a newer picture because that looks like a regular toe. He went on and he plays in college and he's playing quarterback and he was one of those patients I'll never forget. Yeah, and the power that we have in our hands with shockwave therapy.
Yeah, that's that case. I remember when you got that call and you're like, I don't know what we're gonna do with this. Comminuted fracture, looked like there's gangrene. I'm like, I would have chosen a SIMSAMP. I mean, my training would have put me in that same position to suggest a SIMSAMP. And I gotta tell you, man, that's for lack of better terms, that's badass. That's what the technology does. So my case is actually one similar. Like my son plays high school baseball, and this is actually their starting shortstop. He had actually a week into the season was running off the field and was giving his friend a high five, and he had a high ankle sprain. Landed on tips of his toes, rolled his ankle on the turf. We're down in Florida, and he is like unable to put weight onto it. I said, we'll go to the pharmacy, get a boot, kind of immobilize it. He ended up having a little bit of an anterior subluxation. I did an adjustment actually on that day. And this was actually the week he got back. So, I mean, just really pretty, edematous, obviously big old ecchymosis. His parents have a specific insurance policy that didn't really allow them to see me, but I took it upon and did this pro bono. But he was told that he was going to be off for about 4 to 6 weeks. And that's pretty much the first half of the season. So I told his parents, I was like, hey, listen, bring Ben on down. I'll start working on it. They did x-rays. X-rays were negative. I did ultrasound. The images showed ATFL was sprained, not torn. Or CFL was sprained, not torn. ATIFL was sprained and not torn. So, I mean, luckily, for the most part, his stability was actually pretty well intact. And I do believe that doing the ankle adjustment did help that. It reduced the stress on the tissues first. I always do that, whether I have x-rays or not. Some people will disagree with that, but I'd rather put the ankle back into its proper alignment than to let it sit and wait and just immobilize it. So, it takes the relaxed tension off the ligament structures. So I did Shockwave, I did radial pulse wave, and I also did focused. And I did EMTT. I gave him the works. I mean, I call it the platinum package. Elise calls it the vibranium package. But really, at the end of the day, I wanted soft tissue healing. I wanted to get that blood flow moving, and I wanted to get those cells opened up. The images on the right-hand side, that's actually 5 days later. It's crazy. 5 days later, it went from the ecchymotic stage on the left to the images on the right. He was actually running up and down his street 5 days after I had done treatment. And I had done 2 treatments in that time frame. So I did them like 2 days apart. We had a game actually that Saturday. So we got home on Monday. We had a game on Saturday. He asked me if it'd be okay for him to play. And I said, no. I said, you can hit, but you can't actually play the field. And he actually hit like ridiculously well. Not saying that it's because of my treatment, but his ability was ridiculously good. So by the time that he hit the second week, he was actually back to playing full-time shortstop, which the backup shortstop was kind of remiss because he was also a senior and they're both going on to college to play baseball. So Ben, at the end of the year, they won the state championship. Again, not because I performed this treatment, but I will say that he made the last out in the state final championship game. shortstop crossing to the right-hand side to third base and threw a ball on a dot to the first baseman to get the final out. He came up and gave me a big hug. His parents were like crying afterwards. And that, to me, trumps the money that would have cost this kid to pay for this. Like that was worth it. That was absolutely worth it. And to see the look on the kid's face to know that he was back in the game, and he is now playing for a junior college. He is their starting shortstop at the junior college level, and he has aspirations playing Division I baseball after this year. So I see nothing that puts him in a position that would deviate from that. But that's the power of what this technology does. And I know that, again, some people don't have the full suite of treatments, but my hope is, and I think our hope is, that you consider it. If you're doing what we're doing, this has got to be part of your armamentarium. So, all right, next slide. Sorry, I got a little soapbox there. All right, this is the last one. I didn't have the initial, kind of lead into this, but Rob, if you want to lead through this this next wound patient.
Yeah, so let me just preface this by saying I hardly see wounds, but they always seem to find me.
Right.
My two cases I'm giving today are both wound cases, and not something that we traditionally think of Shockwave for. So this was an 82-year-old diabetic male who presented to me after being in a convalescent period at a hospital. He had he's neuropathic and misses the gift of pain, as Dr. Armstrong calls it. And unfortunately, he had some kind of AFO on, and he didn't feel what was going on there. And then lo and behold, they actually saw drainage on his bed, and they're like, "Oh, you have this." So they discharged him with this, with nothing. Comes to see me, and I was like, oh boy, here we go again. So my first thing, I wanted to just send it to wound care because I wanted to be done with this. But I had just gotten off dealing with the young fella that you saw in the other one. I'm like, maybe it'll work on this. So did a combination of EMTT and radial shockwave around the tissue, kind of like a dartboard, kind of go bigger, smaller, and then we did focal shockwave going into that area. We covered it with a Tegaderm, or you could even use saran wrap if you wanted to, and gel. And this guy, 82 years old, diabetic, healed perfectly. I will tell you, it's a little uncomfortable to get this done. So, you have to, once again, give realistic expectations beforehand. Even though he was neuropathic, he still felt it in a deeper way. So, but I wish you could see the progression, but it happened really quickly. That black eschar went away pretty quickly with minimal debridement on my end. Just kind of cleaning it with saline and not doing any sharp at all for this. And it healed up, and he has been great ever since. I pop in every once in a while just to tell me he's really happy. So yeah, another application that you wouldn't normally think about.
Yeah, I wish Rob didn't have both the wound care cases, because we don't see wound care a ton. I mean, our practices are, pretty similar in that sense. It's like a bad penny when those wound care patients come in, but if you have the technology to be able to do it, and I've had similar situations where, it's just a non-healing wound. They're, compromised vasculitis, or, in this case, diabetic neuropathy, that you're just like, do you send them for wound care? Sure. But, when you have the technology like this, it sets it up really nicely. And sometimes you do have to send them for wound care regardless, but at least get the wound bed clean enough to where it can accept a graft or something like that. So
yeah, I mean, but that you're right about that, Mike. But here's one, didn't even need a graft.
yeah.
I thought this was definitely going to be something that needs a graft or something more invasive, but worked out really well.
That's awesome. So the treatment plan, actually, we've been working on as a project, I would say, with ASMST, which is the American Medical Shockwave Society, with Tissue Regenerative, the platform through CureMedics, and just kind of looking at different applications, for radial pulse wave in this case, you're adding focus shockwave, if you're doing EMTT. And for those who don't have those technologies, let's just even take radial pulse wave. Sessions are typically done weekly. I say 4 to 6, but I think a lot of people are kind of moving to 6 sessions, and those are done weekly. I do have some patients where you can skip a week based on their travel schedule, so you can do them every 2 weeks. But on the handpiece, and we're talking about STORZ products in particular, 2,000 pulses. There are other products out there, and we'll kind of talk a little bit about that at the tail end of this. It may be different, and I'm not talking on obviously some of the other products that are available in the U.S., but this in particular, STORZ is kind of the one that we are using. Communication, Rob, if you want to kind of hit on the communication side.
Yeah, I mean, we're pretty upfront with the patients. They need to know that healing is biological. It's not going to be instantaneous. It's not even linear at times. You might have good weeks and bad weeks. Myself, I usually do 6 sessions a week apart. But my rule of thumb is I tell them, listen, I don't want you to go longer than 2 weeks between sessions, and maybe we keep it to within 72 hours between. And I tell them, like, the goal isn't here to mask the pain. Like we said before, it's about regenerating it. And when you explain this, that it triggers the body's like natural healing cascade, they're pretty compliant.
Yeah.
They seem to understand the bigger picture and better long-term function. It's not a quick fix. I also think it's really good to complement things like physical therapy into it. And it makes the physical therapy sessions more productive because they're not having as much discomfort. So I'm never saying it's going to be the one and only thing you need to do, but it definitely complements the synergy between it.
Yeah, I agree. I think you don't want to extend beyond 2 weeks. I do try to give ranges as far as tissue healing. We also track it with imaging. So that part of it is really important, is that, if you have ultrasound in your office, obviously X-ray for bone healing, but if you're tracking it, you can see those changes as the weeks go by. And I usually do like a 4-week follow-up, 8-week follow-up, 12-week follow-up, and it offers at least a visual for patients for something like Achilles tendonitis or plantar fasciitis to see those tissues go through the modulation. And as they're going through pain reduction on top of it, the visuals kind of tie in really nicely. So that's a plus for having in-office imaging available, especially for soft tissue. And I think we mentioned it at the tail end of this. You're supposed to feel sensation. We don't put local anesthetic on board. So we don't inject around the Achilles. We don't inject around the plantar fascia just to get a number to elevate that to its highest setting. We want to make sure that they identify where the sensation is coming from, because that's a pathologic tissue that we're working on. You see that maybe more so with a focused shockwave system, because that is pinpoint. You want to make sure that you're in the tissue that's affected. And with radial pulse wave, it tends to be more broad and more general. But that's the reason why we don't use local anesthetic. And that's probably one of the biggest questions we get. Can you use local anesthetic in the area? I think you're doing yourself a disservice by doing so. Yeah, that biofeedback is really important. So last, we talk about cash-based model benefits, and it's interesting because I've been doing Shockwave less time than Rob, but what I find is that a hybrid model with insurance allows you to do and get obviously a patient base, and also it allows you to do the imaging in the office visit. So people have gone completely cash-based. I think you may be missing out on that opportunity of patients are going to come in, they want a treatment plan. You can offer a menu or a suite of options, but if it points back to the cash-based model of Shockwave, you at least have that as an option, right? So, the hybrid model for insurance-based, I think, is still important. Cash is king. I mean, I got to tell you, I'm not cheap. I live in Chicago. I practice in Chicago. My costs for the whole suite, if I'm doing a treatment, it's $400. I'm not going to lie about it. I'm not the cheapest, and I'm not the most, well, I am probably the most expensive in the city. But I would say that it also comes with experience. And once you get your hands on it, you may start out with very, small, I would say cash offerings. Maybe it's $100 for your radial pulse wave. But if that's the case and you start seeing the benefits and you start seeing the experience kind of come through, you're probably going to start saying, you know what, maybe that $100 is on the low end, or you can keep it there, however you want to play it. But at the end of the day, you do have to kind of make a living. And I'm going to say I'm not shy about how much I charge for the system setup that I have. So, what do you think, Rob?
Yeah, I mean, one of the biggest things, the benefits is that you're offering a premium evidence-based service outside of the insurance model, which is kind of neat. And I think that it empowers the patient to invest into something, invest into themselves in order to get better. I think patients seem to value it more when they invest into it as well, and you know, I just think that it also expands your access to other patients that maybe would not otherwise like do it because they were locked in by just insurance-based models. So I think it's definitely something that, like I said before, it makes you stand out. I don't advertise at all, but I'm invested in getting people better because my advertisement is happy patients who tell other happy patients. And in the athletic community, they talk, they chat. You have moms at a gymnastics event, they're going to say, "What did your daughter do?" "Oh, I'm going to go see that doctor." And that's there's your motivation, get them better.
Yeah. It's interesting. This past week, I've had two referrals through GPT, like a chat GPT or AI, and I had two through Reddit, which I never knew that people actually would talk about foot and ankle podiatry stuff, no, let alone like a referral. But the word of mouth is huge, and you don't have to spend a ton of money on advertising to put it out there. Patients speak. They tell patients, they tell the runner that's in their club that's having the same issues, their coworkers, and it kind of spirals into more patients. So improving your practice revenue is just by virtue of the outcomes, but the technology has to be the part that works. And if it didn't work, I wouldn't do it. I wouldn't be here. I
Yeah.
wouldn't be talking about it.
I mean, I'm sure there's a lot of different types of people on this call right now. People who have systems, people who don't are just new to this. So if I was going to give you one pearl, it would be start with one system, master those protocols, and lean on the CureMedics team. They're really good. I mean, they have great people who will help you. And I always find it's the people who know the most who are to be the ones who are the most willing to offer their talents. They're just phenomenal partners.
Yeah. And I think longevity speaks volumes. And what the studies have been done with are typically Storts. It's Storts products, and that speaks loudly. The people who we've learned from, and especially the technology side, are coming from Germany and Austria and Switzerland and
South America.
obviously South America, and it's incredible the amount that outside of the US that it's being used. We are like fledgling in our society. And I think as American, practitioners, we need to kind of get on board and take this by the reins because we are supposed to be the leaders in many things. And I feel like, thankful that we have this opportunity, both Rob and I, to do this, but we're leading a charge, hopefully to see patient outcomes improve. And I think, Americans deserve that. So.
I have a question for Dr. Chin. You know, could you imagine, like you've seen the results that you've had over the years. Can you wonder how you practiced without it?
I had to tell you, I'd probably be more surgical, to be honest with you. I mean, I trained surgically and I'd have that surgical mind, but to be honest with you, as I get, one step closer to retirement, I enjoy doing the non-surgical stuff. If I never had to step foot in the OR ever again, I would. And, I do cases, now twice a month. That's okay for me. I think this literally satisfies all those things that we talked about. Again, patient satisfaction is the first. I like to be liked, right? I think Rob, you and I are the same way. Like we want to be, part of the team, but we also want to be like that person that gets that call from somebody who was referred to, by another patient. That's like that's the best medicine for me. That's what makes me get up in the morning and go to work every day. So But yeah, I mean, honestly, I think you guys have to assess out the options as far as what manufacturers, distributors there are. We're going to tell you that CureMedics and STORZ are the best team. They are. They flat out, they respond. They're on the ball. If you have a problem with the unit, I don't think there's a better team out there that jumps on it. I just had somebody work on my unit this past Saturday. It was a small little thing, but literally somebody stepped up and was able to take my unit apart on a Saturday, dropped it off at their house. Bingo. I don't expect that from all the service people, but I will tell you that meant a lot to me because I'm I'm needing that system be ready to go come Monday. So. But yeah, Rob, I love you obviously, and you got me into this craziness called Shockwave. But yeah, if there's anything that you want to part on these lovely people, what else would you say is on your mind?
Um, be the innovator. Be willing to take a risk. You know, the science is there. It's not something that is a magic box. I think the other thing too is that it will not work 100%. It will
Yeah.
not. Be a physician, not a technician. So if things are not going the way you want it, reassess.
Mhm.
Maybe see, did you have the right diagnosis to begin with? Maybe you didn't. Maybe you thought it was a tendinopathy and it was really a nerve issue, or maybe it was coming from the low back. Reassess. Also, setting those goals and realistic expectations. That is the key to getting people better. Because you know what? It might not be better after 6 treatments. It might get better after 6 months. But
Yeah.
you have to know how to pivot when you're dealing with a patient who's saying, I just spent a lot of money for this. Now what do I do? You got to know how to talk to them. That's part of being a physician. So for your young doctors out there, try to practice those skills. That's really important because everything isn't 100%.
Yeah. Perfect. Those are great words of advice, Rob. I use those every day. So, all right. I think we are at the end.
Yeah.
We have I think a Q&A session, right, Anne?
Yes, there are a
I'm not able
bunch
to
of
see the chat
questions.
feed, so
Let's go here and see what we've got. All right, I'm going to start at the top. What is your protocol for ganglion cyst?
Yeah,
You
so I'll
want to
take that. Yeah. So my protocol is to always do what we were always taught in the past, is to try to drain it. And if that does not work, or if it becomes repetitively filled within a week or so, then I will drain it once again, and then I incorporate focal shockwave to that area, and I usually do 1 to 3 sessions for a ganglion cyst. And with compression afterwards, and it usually works quite well. Even for smaller mucoid cysts, I've done it. It works really well.
So when I do larger ganglion cysts, I'll use a 64 blade. So instead of using like a 18 gauge needle, and I'll basically, in a sense, aspirate, but it basically is just draining that ganglion cyst. I'll use if you only have radial pulse wave, if there is a tip that I would say is one of the game changers, is using what they call the Atlas tip. It's a silicone-based tip, and you can use it over bony prominences, and it literally just helps flush and keep that tissue matted down. And when it heals, you don't have that rent in that tissue anymore. And again, recurrence rates are virtually, it's zero.
Yeah, I mean, I think one thing I would also add to that, and this is something we didn't really talk about, but if you're going to be using this technology, you should also be using and be very proficient in utilizing diagnostic ultrasound.
Yeah,
Because it shows the pathology well. You're able to direct it where it needs to be, and then the patient sees it and they can see the results afterwards. Because patients want to be educated. And if you can educate them on how it goes, they're going to be more compliant.
Yeah, especially if there's multi-lobulated lesions too. Sometimes you need to do maybe 2 or 3 different stabs at it to kind of get those other lesions. And sometimes you'll feel it, but when you look at it under ultrasound, you'll see that deflation of the ganglion cysts, no problem.
So Just to clarify, because there's another question about it, did you excise the cyst and then use the shockwave, or just the shockwave?
Just the shockwave.
Well, we
Okay.
aspirate the cyst, but
Aspirate. We don't, we don't.
we're not surgically excising those. That's just, aspiration in the office. You could do that with a 18 gauge and a syringe, or you could do that with a 64 blade. Yeah, so it's not surgically excised.
What about fibromas?
That's a great question.
I haven't had as much luck with fibromas, to be honest with you. I know that there is a lot of cases that have been done with Dupuytren's, which is kind of more in the hand and in the hand. But personally, like I've not had the success rates for that of fibromas. Rob, what do you think?
I find it works as an adjunct with a compounded medication. It definitely softens them a lot more. It might not eradicate them, but when you soften them, they become less painful. And I think that's really the way. I use a combination approach with the compounded medication.
Yeah.
Are you using shockwave for perineal tendonitis?
We use it for every tendon,
Yeah. Every
every
time
tendinopathy, so it doesn't, we don't exclude any.
the collagen's the same. So you can use it on any one of the tendon structures.
What do you charge patients for these services?
I'm pretty honest. I charge $400. I have EMTT. I have both shockwave systems. I'm at $400 per session. So if we do 5, it's 2,000.
Yeah, I do 370 per session. I do 6 of them, so it's 2,000.
I just do one less, but I do sometimes will do a 6th one. It just depends, how the patient's responding.
And on top of that, I've given away more shockwave than most people have done. Because if it depends upon the scenario, like that young fella who had the gangrenous scenario, I didn't charge him when we did it like 8 sessions for him, but
Yeah.
it just touched my heart, so I wanted to get him better.
Yeah. Same with my guy with the ankle. It's like, I felt bad charging the patient, the parents for that. I did it pro bono. So.
Yeah. Earlier, Dr. Continelli, you mentioned that you don't do it on pregnant women. Is that standard for the device?
Yeah, it's one of the contraindications, and honestly, I mean, after talking to other experts around the world, there's probably really no reason why you couldn't do it, but you don't want to have that link to you wait to 9 months. Let's see what happens, because you don't want to be that one that it happens to. That's my personal feeling. Michael, do you agree? Or?
Yeah, I kind of agree with that too. I mean, I know that shockwave contraindications were if you're doing pelvic, kind of pelvic area or regions. But I would say the same thing. Like the last thing you want to do is, have a premature, birth or, something that kind of happens. Then they're pointing to you, saying that you did shockwave on me. So I try to be mindful of that as well.
Have you heard of any contraindications in the pregnancy with potential ear damage to the fetus?
That I don't know. I wouldn't have any, I don't know of any cases, but I would also say that I'm not treating up at that location. So I think that would be proximity based more than anything.
I think I get more ear damage than the fetus gets, and maybe that's just because I'm getting older.
What'd you say?
I get more. Yeah, exactly.
Can you give your protocols for Achilles tendonitis from week 1 to week 8?
Talk about that, Rob?
Yeah, so I don't know why it would be week 1 to week 8, but it would be week 1 to week 6, and thereon afterwards, because it's 6 sessions that we do usually. It's usually to, like we said, work from the outside to in. So we work to the musculoskeletal areas as well, finding those trigger points. So we'll usually use the radial pressure wave up into the gastroc, bringing it down into the tendon area as well, and then find the area that's most point tender. And I usually will mark those areas. And then we use our focal shockwave as well. I start it all off at the very beginning by doing EMTT. I will tell you a quick funny story about that. I always mark my areas. And next week, one patient came in and she said, "You're a genius. I feel so much better. My Achilles never felt any better." She goes, "But you burnt me." I'm like, "Well, shockwave doesn't burn. There's no heating element there." She goes, "Well, there's a black mark on my foot." I'm like, "That is a Sharpie, and you should use soap and water when you bathe." So after 7 days, I shouldn't have still. So.
Awesome. And if you just have radial shockwave, you can do those same treatments along the trigger points in the calf, the Achilles. You don't have to have EMTT, and you don't have to have focal shockwave for the Achilles tendon, but it's the same protocol. It's 2,000 pulses. I usually use, there's actually two applicators that you could switch between. One is called the deep impact, which is what they call the DI-15, or you can use the red. It's almost like a concave impactor that kind of focuses a little bit more of the pulse wave into the Achilles tendon. And I find that those two work really well. If you don't have one, you could use the other. But you want to start out with kind of low, the measurements are bar pressure. So you're using kind of lower bars to start out, maybe a higher frequency. But I always try to get to a frequency of about 12, 10 to 12, and then increasing your bar pressure to somewhere between, if you can, to get 1.5 to 2.5 on the Achilles tendon.
Yeah, and the other thing, we talked about this many times so far, it's not a magic box. So you have to tell the patient that they have to do eccentric strengthening exercises. We have a protocol for that. We tell the patient not to be using anti-inflammatory medications because it's contraindicated for that, and not to use ice. We want to use heat to increase blood flow.
Yeah.
How effective has the shockwave been on osteoarthritic joints?
Take that, Mike.
Yeah, as a standalone, I find that it's more working around the soft tissues, so the capsule, the ligament structure. I probably use the EMTT more for the osteoarthritic cases. And if I can, to get whether the patient's doing manual therapies on their own or the physical therapy, but occasionally we'll do the soft tissue structures around the joint. And again, like that Atlas tip that I talked about, or there's one that's more of a poly tip. That's a plastic kind of tip. Those are a little bit gentler around the bony structures. I find that those actually probably perform the best along with electromagnetic transduction, or EMTT.
Agreed.
What does EMTT do that shockwave does not do?
So
It's a-
EMTT, what the whole idea behind it turns magnetic energy into electrical pulse. And that electrical pulse opens up the membranes within the cells, making them more porous, allowing to get rid of the things that cause some of the discomfort, setting up a good bed for what we're going to do next by allowing the stem cells that we're recruiting to that area to more easily get into those cells to help it heal. So that's what EMTT does. It's kind of like the starter. Shockwave, especially focused shockwave, like we said before, differentiates those stem cells and recruits them to that area.
Yeah. We use a lot of EMTT for bone edema. So I've been seeing a lot of talar bone edema cases, and it could have been an ankle sprain that diagnostically those ligaments were fine, but the actual bone was more the pathology. And using EMTT, it opens up those, cellular membranes, but it increases kind of the catalyst of getting that tissue to turn over at a faster rate. I call it the cell stabilizer. And it helps kind of work on inflammatory processes. So it does flush, I would say, really well to get the products, kind of the new products in and the old products out.
We still have a bunch of questions in here, but it's 9:04, so I'm good with going on, but I want to hear from the audience. Do you guys want us to continue with the questions? Give me a thumbs up.
Well, there's one.
All right. Oh, and another one. Okay.
Only
Elise. I'm going to put you in the hot spot. Can you look over this list of questions and see what's on here that should definitely be answered?
Oof, that is putting me on the hot spot. Okay. Dr. Chin, that combination of using laser therapy. We work with a lot of people who do have laser as well, and it can work great in combination.
Yes.
Question is, why didn't you use that to the treatment of the patient with the ankle sprain?
So time, part of it. And I was actually really interested to see how I do have laser. So I have MLS laser in my practice. In his case, I wanted to see if I can do it without, and a lot of it was just timing. I was squeezing him in for treatments. And when I look at the suite of treatments, if I look at the total, you're looking at about maybe 30 to 35 minutes to do the treatments from start to finish. If you add laser to it, you're adding another maybe 15 minutes to the treatment. So I do use laser quite a bit. It's an extra charge, but it's a really good way to bridge kind of the pain gap between the treatments that I'm doing with Shockwave. So I do use MLS treatments kind of for nerve pathology, wound pathology, post-op pathologies. So it is part of my practice, but it does a really good job of bridging between treatments for pain and also for inflammation.
And along those same lines with that ankle sprain, how long after the injury did you use Shockwave? And was it painful for the patient?
So so we got back on Monday. I got him into the office on Tuesday. So he went to orthopedic visit on Monday. He came to my office on Tuesday. I started we're talking 4 days. We're down in Florida, so that happened on Saturday. We were back in my office in 4 days. So I had no problem treating acutely.
Hey, can I answer two of these questions I see here? Because I think they're both good questions. One
Go
question
ahead.
is, when treating fractures or using radial focused or both. When treating fractures, I only use focused Shockwave because it's the only one that goes deep enough to that area to really make a difference. That's my opinion when it comes to that. And the other one was, does increasing the hertz decrease the efficacy? It doesn't decrease the efficacy. However, what it does, it decreases the pain, so that biofeedback that you get from the patients is not there. So you almost want to go on a lower hertz first, just so they can feel it a little bit more, and then once you know where their most amount of pain is, and you can increase their hertz to a certain degree.
There are two questions here that from Stavros, and one is, when do you apply the injectable, like the biologic, for the regenerative product? I usually do that after the second treatment. So I kind of do a prep. The first week is a Shockwave, second week a Shockwave, and then the injection follows that Shockwave on the second week. And then as far as the pressure being applied to the Shockwave unit, you do want to be there. There's actually in certain units, and I would say STORZ has it, you can actually press and you'll see like a depth gauge, like how much pressure. It's kind of green, or I think it's red. It kind of shifts, but you don't want to go so deep that you don't want to be on the surface, because all you're doing is you're getting percussion on the surface of the skin, and that can actually be pretty sensitive. So you want to be deep enough to almost like about maybe a 1/4 inch down into tissue, and more of the like plantar fascial areas, Achilles, maybe a little bit less, just because the skin's a little bit thinner. But I can't remember how we tend to gauge it. It's based on feel. So if you're having a staff member do it, I think that's really tough. I do all my own treatments, so I don't have staff doing the treatments. I know there's a number of docs who would beg to differ on that, but I want to know like the depth based on how I feel and what my feeling is on the patient. What do you think, Rob?
I think for $400 a session, I want Chin doing it. To be quite honest, yeah. And I think that I mean, a different protocol for different tips, right? So we have different standoffs, and you don't have to really put a lot of pressure to get this to work. You want to just find the right tip and that feel comes from doing it all often.
Yeah.
It's definitely a
I'm going
learning.
to ask one last One last question, if that's okay. There's a lot of miscommunication out there. Shockwave is a bit of a darling now. It's evidence-based, lots of level 1. Unfortunately, you have a lot of companies out there who stick a wave behind their name and call it FDA cleared, FDA approved. Why would you tell your colleagues it's important to vet out what device they're getting it from home?
I mean, listen, there's a lot of products that you can get from Alibaba, and you don't know what you're getting, and those are not products that are necessarily vetted out, and they're being sent over here. I think you're putting yourself at risk. If something goes wrong, a patient goes south in any way, shape, or form, that's your license on the line. I think what we can say, both Rob and I, and this is because we've vetted out the products. There are products out there that just don't get the same energy and the same depth of penetration to the tissues, and you have to do multiple treatments. So you're doing 15 to 20 treatments. I think that's kind of absurd. If you have a unit that can do that heavy lifting in such a small window of time, we vetted it out for you. I mean, that's the end of it. I mean, I know that we are KOLs for CureMedics, but I'll tell you, if there was something else that came about that blew my socks off, I would take a look at it. But I just have not seen anything that really does what STORZ products do.
You gotta understand, Michael and I have also been really fortunate enough to go international, and we just got back 2 weeks ago from Bogota, Colombia, where they had the ISMST World Congress, and we're blown away by the number of different manufacturers of Shockwave that we just don't see here. And they all have certain things that they're quite good at. Not one of them does all the stuff that STORZ and CureMedics does. And on top of that, the people who we respect, who do the studies, they're using STORZ and they're partnered with CureMedics. So, I want to be part of the cool club. So it's definitely, it's definitely, there's a great camaraderie amongst professionals through that group. Not there's anything wrong with some of the other ones, but there's just more.
Yeah.
Great. Thank you.
All right, I'm going to go with one more question, and it's hard to pick one. But I will send all of these questions to our panelists so that they can reach out directly. And did you guys share your email addresses at the end of your presentation? I didn't catch it.
Oops.
Okay. Well, if you would like to type them into the chat, you can, and then our attendees can reach out to you with any direct questions. That's up to y'all. So which would you prefer to use for acute plantar fasciitis, laser or shockwave?
Shockwave, no doubt.
Shockwave, but I have both, so I do both. If the pain levels are really off the charts, like 7, 8, 9, I'll probably throw a laser on there too to kind of calm that tissue down. But that's only because I have it too.
Yeah. All right. Is there anything that you guys think that we should touch on real quick before we say goodnight to everybody?
You know what? Here's something. If you're not sure, if you're on the fence, call us up. We'll talk to you. Why not? I want more people to do this. I want the docs down the street for me to do it because it just makes it more real. I think there's so much good stuff there. But if you're not sure, come to my office. I've had doctors come from across the country who just spend a day looking about it. More than willing to show you my protocols, share with you, and have you learn. I think that's the best way to learn.
Yeah.
Or go to the events held by CureMedics because they're excellent. There's one coming up in December.
I was going to say the Tissue Regenerative Conference in Boston. There's hands-on programs that are being held throughout the country. ASMST is going to be in March, which is basically our new American Shockwave Medical Shockwave Society. Get involved and learn about it. And I would say the same thing. Don't hesitate to reach out. I think we're both pretty affable. We're reachable. We can field questions and things offline. So, I'm not shy about, sharing what I learned and what I can, expound on knowledge wise.
Come join us next year in Madrid.
Yeah. The
Yeah,
World Congress is
the
in Madrid next year.
ISMST.
Yeah, ISMST in Madrid. So
Yeah.
it's awesome.
That sounds exciting. Well, thank you guys for your time. Thank you for the fun we had. And thanks to Curamedics and Elise for sponsoring this. So we will see you all at the next ones. And thank you again, everybody.
Thanks so much.
Thank you.
Thank
Thanks,
you.
Anna.
Good night, everybody.